lovely. Thank you. Let me test the sound real quick, too. See if I can work White Mark's ears gunk off. Yeah, you can hear people very well. And then I'm supposed to push a button.
Did he give you a little training session?
Or maybe I'm recording now. I'm very possibly recording.
First step, first baseline step. So we do an assessment when they come on board with us as a member, and we do what we call lower extremity examination. We feel it's important, particularly for our diabetics. We issue them diabetic shoes, and that is through our podorthos or through podiatry services. Our podiatrists, our services are offered 6 times a year at no cost. That's a real big plus for a diabetic, particularly for those individuals with neuropathy. We say they can go 6 times at no cost, so they can get their nails trimmed and their foot checked on a regular basis. The shoes are dispensed to them at no cost, and they can range anywhere between $70 and, I don't know, $300, $700, depends on the orthotic that goes in or the type of shoe that that person wears. We also provide them with some form of foot probe, temperature probe to check the temperature, because someone who has neuropathy is probably having a lot of inflammation in their feet, temperatures rising, ulcers develop. And so what we found through disease management programs, our parent company, Excel Health, they found that through disease management programs that they could reduce amputations by approximately 55 to 65%.
Any other special? There's nursing. Any other specialties? Social work. Excellent. Well, the talk talks about, the talk that I'm presenting today talks about the future for physician assistants in medicine and primarily in geriatric medicine, but the demographics apply to everybody, and some of the things that I'm going to be speaking about will apply to everybody as well, so hopefully you won't be too bored. So the question I have is time travel possible? Yes. A student of physics, right? String theory. I like time travel movies, and one of the reasons I think that I like time travel movies is because I like history, and history is always sort of instructional in terms of what happens in the future. So in thinking about our history together, I was thinking about how did it come about that I became a physician assistant. And it was about 19 years ago today that I walked in anatomy lab, cadaver lab, as a PA student. So what a journey it's been, and I think I remember, if you've been into a dissection or seen a cadaver, the very first time that you're involved in that kind of strikes you that, this was a person, and although the tissue's, degenerated and gray and it doesn't look like live tissue, usually you'll find some little trait on your cadaver that reminds you that that's a person. And it might be, the indentation from a wedding band or fingernail polish was left on one of the cadavers I worked on. And the profession, for me, has always been more about people than about guidelines, than about JACO, than about HIPAA, than about all these things that we talk about. So when we talk about geriatrics, we need to remember that although I show a lot of charts with numbers, that all of the numbers represent people. So what's the plan for this morning? Well, it's going to be to talk about PA practice in an overview, but very quickly. And I'm going to talk about demography, but I know you got beat up with the demographics lecture already. You've already covered many, many charts on the future demographics of the geriatric population in our country. So I've seen that, I'm aware of that, and so I won't put you to sleep on demography, but I will talk about it. And then we'll look at the historical perspective, because again, is time travel possible? Can we predict the future based on the past and based on the present? And I'll give you an overview of an analysis of the PA practice data available from the state of Texas, and then we'll talk about some opportunities for PAs in primary care. So one of the things that, if you're not familiar with the profession, you may not know what it is that PAs can actually do. And our job is to primarily do what the physician tells us to do. We have practice that's delegated to us. We are dependent practitioners. That means we work under the physician, just like the dental hygienist works under the dentist. But you're doing most of the visit. And you know, initially the idea was that the PA would see the easy things so that the physician would have time to see the more complex cases. Well, that was probably verbiage that was used to sell the profession to uncertain physicians initially, but now we're used in an extender role, and in some cases we unfortunately, I think, replace more than extend in many practice settings. And I'll talk about why that is. And I'm not necessarily a fan of us replacing, but in some instances we do. We diagnose and treat illness, we order tests, we interpret those tests. I did a study looking at the expectations of physician assistants in 1977 and compared them with the expectations of physician assistants in 2003. I repeated the same study and I found that PAs wanted more autonomy, more money, less hours, but there was one thing that PAs wanted more supervision in, one thing, and it was the interpretation of diagnostic tests. They wanted more supervision than in 1977, and I think that may be reflective of the fact that diagnostic testing has come a long way, is very complex. We're now into pharmacogenetics, where now we're going to look at your genome and see what drugs are going to work well with you and what ones aren't. So it's very, very complex, and it is something that I think that PAs want help with. We assist in surgery. We obviously write prescriptions. The drug companies know this. They used to not know this, but now they do, and now they market, you know, directly to PAs and support PA meetings and support the profession. And also, we perform other tasks that are delegated to us. Well, again, demography slides, you know, these are the population pyramids. You have them in your book. But basically what's going to happen is, over time, you have some elements other than the fact that you have just more elderly people. And what I challenge you to think about is the other elements related to demography. And, you know, obviously in the elderly group, fertility is not an issue. But mortality is a huge issue, and you've talked about life expectancy, and you've talked about some of the things that have happened, that are happening with mortality. Now, as we push that triangle that then becomes a square, as we push that into a more square pattern at the end of life, where people are living until, say, 100, and then they drop dead. You know, I mean, that's basically some people's ideal of medicine is let's push everybody to 100, and then they silently fall asleep at 100 or 120. I mean, you know, if you're fighting disease, that's sort of the issue, right? The problem with that is that there's a lot we don't know about in terms of the quality of life in that last period. We're spending a tremendous amount of our resources to achieve that squaring off of the mortality curve. But the question's going to be, how much of our resources are we willing to spend to square off that curve? And what will the quality of life be in those top numbers if we bring everybody into that pattern? The other thing that we don't think about, we don't think a whole lot about, although they did cover it in your prior lecture, we don't think about distribution of people, how the population is distributed, where are they actually living, where are they deciding to retire. Those issues are important. Well, I stole this slide from Steve Murdoch, the state demographer, but I was in his demography program and I suffered in one of his classes, so I think he probably would allow me to take this slide. And basically it's showing you, it's breaking the population not only by age but by ethnicity. And I think sometimes we don't really, you know, I think at UTHSCSA there's a lot of coverage on cultural competency as compared to a lot of places, believe me. So you are getting training in cultural competency, and you are seeing a culturally diverse population. And I think that's great. When you look at the numbers, what do you see? You see that in Texas, the elderly population is more Caucasian, and the younger population's more Latino. And that is a tremendous difference up there. I mean, in terms of demography, in terms of these charts, in terms of percent differences, this is huge. It clearly looks fairly huge, but it's If you think about taking care of patients and you think about resources, this is huge because there is going to be a competition for resources. Like there isn't already, there's going to be a much larger competition for resources. One of the scariest things you can look at in terms of a chart is the anticipated Medicaid expenditures in the state of Texas over the next 20 years. And frankly, I don't think the state realizes how much money is going to have to go into Medicaid. If you look at the real numbers on quality of life, cost of living, average wage, those kind of issues, what you see is a population in Texas in the future that has less of a lifestyle, less resources, not more. The resources are also going to be split. You'll have the baby boom generation, which started in 1946, retiring, and many of them have quite a bit of financial resource. So many of them are going to be able to pay for your services. But the question is, on the other end of the spectrum, the young Latino population, are they going to be able to pay for your care and for your resources? So we're entering a new phase in the state of Texas. So if you have been to the gas pump lately, you understand this. I'm living in Austin now, and I paid $3.18 a gallon to come up here, or come down here. So that number is going to increase. That number is going to increase. And so we know that these expenditures, we know that there's going to be issues in terms of cost. And now we have this phenomenon, the young old. A new group, right? These pictures demonstrate the expectation of the older populations. You know, knock out of your head the image of grandma in a rocking chair on a porch. Knock that out of your head right now, because this group, this cohort, more than any prior cohort, expects to be active. They expect to be young old. They expect to travel, you know, and they're going to have the resources to travel. What does that mean for you in South Texas? Well, it may mean that you see people that come here for the winter, go somewhere else for the summer. You may see people that are just in a tour bus, touring around the country, and they don't have a good primary care health care provider because they're on the road. So being able to take care of those issues, those health issues that come up, where's that going to happen for the people that are very mobile in their elder years? It's going to happen in the ER, isn't it? That's where it's going to happen. So ER becomes primary care in this model. Well, we have other expectations with young old, you know? I mean, look at all the treatments that I put up there, and I bet you can think of more that I left off. This is a new age in medicine. We're not only trying to fix disease, we're trying to repair the cosmetic damage created by age, things like hair transplants. We're trying to fix total joints, you know, degenerated knees. And not only are people having a total knee, you know, young when the arthritis first gets bad, but they may have to have a revision total knee because they're living, if you do a total knee or a total hip at the age of 60 and the thing lasts for 15 years, you're going to do another one at 75 or 80. So revision surgeries occur as well. So that's, and they're more expensive and more complicated. You know, you have the idea now for some people that they can live forever. Not just 80, 82, the life expectancy. Not just 100 because their grandmother did. Not just 120 because that is what we know to be about the end of life, the possibility for human beings. But people wanting to extend that even further. People wanting to live to get forever. And I think part of the reason is that in our society we fear death. We don't have a good mechanism to incorporate death into our culture. Other cultures do very well in this regard. It becomes another aspect of life, but our culture fears it. And if someone dies, what's the next thought? Whose fault is it? Right? Did the healthcare team make a mistake? You know, and so somebody's sort of always pointing the finger in our healthcare system and in our society. So it makes you concerned that there is a mismatch on expectation and what we're able to deliver as healthcare providers, whether we're PAs, whether we're dental hygienists, whatever our role. Now, if you remember why PAs came about, initially it was because there was a considerable, what was expected to be a considerable shortage of physicians. There was a report that was put out, it was called the Bain Report, and it was put out by the government, and they basically predicted this huge crisis, that there were just not going to be enough physicians. So this led to the PA profession really getting started. If the Bain Report hadn't come out saying that there was going to be a crisis, PAs never would have probably existed. So then in the 1980s, it looked like that the Bain Report was wrong. It looked like that we were going to have enough physicians. Maybe we really didn't need this profession. And PA programs started to dwindle off, applications dwindled off, and that was really good for me because I got into PA school in the 80s. I mean, right now, you probably have, you know, more than 10 or 12 people applying for every person who gets into PA school. When I got into PA school, it was much different. So now we're facing a physician shortage again and a maldistribution of physicians. In fact, Texas, for its recent population growth, is short physicians at the present time. And there are some factors that really make this worse. I mean, the aging of the physician cohort makes this worse. Early retirement patterns on the part of physicians make this worse. If you think about it, the baby boomers are hitting their healthcare need, but some of the baby boomers are doctors and dentists, right? And nurses. And so these aging professionals, they're kind of looking at lifestyle now. They're kind of thinking they've done their work and now it's time to enjoy the fruits of their labors and all their years of service and dealing with all of the complexity of the healthcare system. So if they retire earlier than we thought, than we expected, than the workforce planners expected, then there's a huge shortage in a time of need. You know, if you've been around, you realize that you have to, on your visits, code, and you have to know all the codes, ICD-9, CPT codes. You have to go take your CPR, you have to go take your HIPAA training, your J-code training, all of these trainings in order to just work, right? So many of your hours now as a healthcare provider are spent training or doing administrative tasks and not really spent in patient care. So the more we ask of you, the more things we ask you to do administratively, the less time there is for patients. And when we multiply that times everybody, because everybody has to do these things, it creates a gap in care. You know, residency hours are going down. Service, the demand of lifestyle and longevity is making it where there's basically just too many patients for providers. If you look at, you know, the age, and this is a slide from a couple of years ago. This is actually, if you look from 1997 to 2003, you can project it up another 5 years to make it current. So you'll see that there is this group that is going to, physicians that's going to continue to age and not be replaced. You know, we're below replacement in that sense. Even adding 30 more students to the medical school class here at UTHSCSA and at other medical schools does not fill the gap. And if you look at Cooper's work, that gap isn't going to be filled nationwide, and especially in Texas, since we're already starting with the deficit. Now, I looked at the physician database in Texas and found that that's 0.11%. That point in there is in there on purpose. Not 11%, but only 0.11 of Texas physicians list geriatrics as their primary specialty. And these are current numbers as of 2006. 3%, now they get a choice. When they log into the state database, licensing database for physicians, and you have to log into this because you have to have a license to practice. So this is capturing everybody. So I went through and checked, and only 3% list geriatrics as a secondary specialty. You see a problem here? I mean, we don't have the specialists, like Dr. Horton said. She said, you know, you need specialty training to pick up these geriatric syndromes. You know, what is she talking about? She's talking about things like medications that combined add up to the anticholinergic dose of atropine, common medications, and create syndromes of dementia, constipation, heart problems, all of these different syndromes that you only see in an elderly person because they're sensitive to these drugs. But if you don't have specialized training, if you don't have the specialized physicians giving the training, you're going to miss it. So it's a problem that we not only have a shortage of physicians, but we have a shortage of physicians trained in geriatrics and practicing geriatrics. Now, if you look at the mean age, I took and checked the mean age of Texas physicians by specialty, this makes a lot of sense. General practice, that term in the licensing is still there because there are many general practitioners. That was something that was used in the past. In the 70s, it'd be very common for you to see a general practitioner. Now, more likely, as time goes on, you'll see a family practice person, a nurse practitioner, a PA in primary care, and then be referred out for specialty care. And if you look, the new specialties, the newer specialties like sports medicine, look at the average age. Makes sense, doesn't it? So the older physicians were working in primary care, and the younger physicians aren't choosing primary care. Is that any surprise to anyone in here? They're choosing specialty. What specialties are they choosing? What do they want to do? What? Cardiology, derm. What else?
Plastic surgery.
Plastic surgery. Radiology. Why radiology? No call. Exactly. It turns out that, you know, it turns out that the same way physician assistants from 77 to 2003 don't want to work more hours, they want to work less hours. Well, the docs, they want to work less hours too. So they're picking specialties where there's less call, where there's more lifestyle, where there's more compensation. It's just human nature. It's not, you know, it's not rocket science. So what's going to make the shortage better? The shortage that we have, well, you can increase the number of medical school graduates, and we're doing that. We increased by 30, right? But how long is that going to take? It's the number of years it takes to get through medical school and residency. That's how long it's going to take. Plus, in order to ramp up a medical school, a new medical school in Texas, for example, it's going to take a few years. So when you add that time together, it doesn't happen quickly. You can hire, you can make more non-physician providers. You can bring in physicians from other countries. So you know what I did? I took the Texas database, and the Texas database tells you where every physician in Texas was born. I don't know, place of birth in the database. So many, many physicians in Texas listed another country. So I actually figured it out, and it's about 30%. 30% of physicians in Texas licensed right now are foreign-born. Well, what does that mean? That means that we are taking away physicians from Nigeria, from India, from Pakistan, from all over the globe, China. We're taking physicians from places where they're needed, where there are large populations in need, and we're importing them. It's called brain drain. So in the United States and in Texas, that's what we're doing. So you can do that. You can increase foreign medical grads. You can try and improve productivity. So how do you improve productivity? Shorter patient visits, right? Well, instead of 30 minutes, you now have 15. Maybe you have 12. Maybe, as Dr. Horton suggested, maybe what you do is say, we want these, you want you to check the hemoglobin A1C, we want you to check their feet, give them a blood pressure medicine, and goodbye. Do elderly patients come into the clinic with that expectation, with a 12-minute visit expectation, it takes them 12 minutes to say hello. You know, it's their social hour. If they're isolated, and who can blame them if I'm isolated and I don't see anybody all week, maybe I go and see a few friends, but if, boy, the doctor's visit is my chance to tell everything about me. It's a social visit. I used to work for a physician in Conroe, Texas. He graduated medical school in 1954, and his patients loved him. He spent time with them. He talked to them. And the same patients came, mostly women, same patients came. He was married, but they just loved him, and they loved to spend time with him. And so their expectation is time, but if you're to increase your productivity, we're taking time away from you, there's a mismatch there. So it may be that then people will turn to diagnosing themselves. My mother does this. You know, she looks stuff up on the internet. Actually, she got a PDR one time, and I think she thought that that meant that she had an automatic medical degree. She would save up pills, you know? If she had extra antibiotics, she'd save them because somebody might need them. Kind of scary. But what happens is, if the people cannot get in to see you, they will go to their friends, and their friends will say, well, this little blue pill helped me. It might help you. You know, and you don't know what's going on in that regard. We do track some of these issues, and it turns out, according to the National Hospital Ambulatory Care Survey, that there is documented increased use of non-physicians. If you look at it as a percentage of visits where you have mid-level and provider both, or physician both, or provider only, you're seeing more provider-only visits. Again, that's not extension, that's replacement. We can call it what we want, but it's replacement. And so you're more and more likely to see a non-physician, and I think this is just going to keep escalating. It's been linear for some time, and I think it's going to continue in a linear fashion. We looked at the national database that's put out from the AAPA, which is the National PA Society, and they track visits. They estimate the number of visits by sampling. And if you look in 2005, look at the numbers that we saw of these conditions related to geriatrics. I mean, hypertension can be in non-geriatrics, but all of these occur in geriatrics. And if you want to really be a good provider, it looks like you really need to know how to treat depression. You look at the number of depression visits as compared to the number of cancer visits or CHF visits. More of your patients are depressed than have congestive heart failure. So you better learn the pharmacokinetics of your SSRIs as well or better than your drugs for congestive heart failure. We're a profession that's growing. Now this is the Bureau of Labor Statistics growth figures. So obviously the number increases, but many of us think that it still falls short of providing the care that we need to provide, particularly to the elderly. The jobs increase, and that's good. It's good for PAs in the room and others in the room who are wanting healthcare jobs. You're going to have a good job. It's going to pay well. In pretty much all the healthcare groups, pay is going to go up because it's a supply and demand phenomenon. Here's Texas PA growth. So compared to where I started, which was on the first end of this curve, I graduated in PA school in 1990, so I'm way down there at the bottom. It's grown tremendously, and again, it seems to still be somewhat linear. There has been a change, and I apologize. Normally a population pyramid is flipped. Normally the females are on the other side, as what I have it here, but you get the idea because I color-coded it. If you look, what do you see? The males disappeared. In the PA profession, these are actual practicing PAs by age and by gender. And if you look, you had very good male representation up until probably the last few years. And males have dropped off precipitously. So we are, we're still not dominated, we have more females than males. We still have a lot of male PAs, as you can see up there, but they're older. The future PAs, most of them are female. Hence, a picture of a female graduating PA. I looked at, our students in their senior year had to track each of their patients by age in a system called Python. It's a logging system. So we were able to look at the data here from San Antonio, and we looked at 50,000 encounters, training encounters of PAs here, and look at the age groups. So obviously the biggest was not geriatrics, but look at that 19% and that 15% that's going to actually move forward as the baby boomers age. So you've got this 20-year cohort that's about to require health care, and it's reflected already in who we're seeing in our training. And so if you base it on a 3-year observation and use a ratio method, Texas has always been, for many, many years, about 6% of national PAs. So using this method, you can see what the expectation is. And it's not, even though it's not growing fast enough, again, to catch up with the need. Especially the need for non-specialty primary care, geriatrics. Now, here's the top 10. This is the good news. So I went and looked at where are the PAs in Texas practicing. You remember we said that the physicians were looking more towards derm and radiology and things where there weren't a lot of call. Well, there are more PAs working in derm now, working in gastroenterology now. Those jobs are out there. But there's not a lot of job openings for PAs in radiology, for example. So many of the areas where there's job openings for PAs are in primary care, where there is a need. They are in internal medicine, in the ER. There are many, many openings now in surgery. So there's all of these opportunities available, and so there's this competition between two models of care. There's a business model where a group of physicians says, if we hire 3 PAs, we can really burn through some patients. I mean, if we're a gastroenterology practice and we make our living doing endoscopy, then we can have the PA see the lady who has the mild belly pain and, work that up, and then she could send them to us to do our endoscopy, right? So the PAs then are being put into practices that are definitely in the business for-profit model. In fact, most PAs in Texas are working in private practices or group practices in the business model. The other model is what I would call the service model, which are places like the VA, the military, university health system. Those are sort of the service model to me. It's not like, you hire PAs because you need the care. It's not so much, it's still a business model, but it's not like the straight for-profit model. So there is this competition. If you look at geriatrics as a specialty for PAs, we're at 0.6%, so smaller than 0.11 for the physicians. The majority list the nursing home or a long-term care facility, and their mean income is about $79,000. There are only 11 PAs in the state of Texas that work for geriatricians. But if there aren't a lot of geriatricians, it makes a lot of sense that you're not going to have a lot of PAs working for a geriatrician. But where can the PA make the impact in geriatrics? It's going to be in primary care. And here's the current numbers. So that's a frequency count comparing primary care to specialty, and I included emergency medicine as a primary care specialty because I think, unfortunately, for PAs working in the emergency room, you're seeing many, many things that could have been seen in family practice. Now, we talked earlier about distribution, and this is called the Gini coefficient. And the Gini coefficient of 1 is perfect inequality, perfect maldistribution. In other words, all the people located in one place. So if you look, this is looking at Texas counties and looking at Texas PAs, and the Gini coefficient for females was 0.74 and for males 0.66. So we're maldistributed. We're in populations where there's 1 million people. This isn't a surprise either, because you know why? The doctors are there. If you have to work for a physician, then you're obviously going to go where the physicians are to get a job. So physicians are maldistributed to the cities, to the large urban counties. And the rural counties don't have large numbers. We have opportunities to serve in places other than primary care. You know, I mean, geriatric patients go through in their lifetime all of these specialties. So you'll always have the opportunity to see geriatrics. And I didn't work specifically in geriatrics in my practice. I worked urgent care, I worked primary care, I worked orthopedics, but I saw large numbers of geriatric patients and dealt with those issues. This lady that I'm showing you a picture of is one of our former graduates. Her name's Barbara Quillen. She is one of the most compassionate people you will ever meet, and she always has that smile. She seriously does. And when she came to PA school, I looked at her and she was so compassionate. And I said, you know, I think we can teach you the medicine, but you can't really teach compassion. But I knew she already had it. She moved back to Alice, Texas, and she started working. This is one of her patients. She sent the picture to me when I asked her. She works in a rural area, which is mostly geriatric. And her patients love her. She goes to the nursing home, and the patients just light up when they see that smile. And that's what it's all about. If you look, and you've seen this, I think, here I'm going to change it back and forth. This is 2000, that's 2040. Blue is 20 or more percent of elderly. So watch. You don't see the cities, do you? The cities disappear. So basically you have a rural population of elderly that are going to have major problems with access. So what are we going to do about that? That's the question. Since I'm not a geriatric PA, I thought I would get the advice of someone who is. One of my instructors from Galveston has been doing geriatric medicine for 25 years as a PA. So I emailed her, I said, Kathy, I'm going to talk to these people. What can I tell them about PAs and geriatrics? And this is what she said. She said, the geriatricians value us. Well, there's a couple of reasons for that. They're overworked, so clearly they're going to value you. But geriatricians are really patient-focused. They're really, really focused on that human aspect of things. And they really appreciate having the PA as a part of the team. She said it's a hardy group, these elderly people. You know? I mean, they have their problems, but they've seen it. They've seen life. They've been through struggles. They do have some coping mechanism. And they are very, very appreciative of the care that you give them, whether it's cleaning their teeth or whether it's fixing their blood pressure problem, and they are very persistent. She said that if you want to do geriatrics well, you need to focus on these issues. One of the big issues is pharmacology, and that lecture that she recently gave at our national meeting was talking about all the hidden anticholinergics in these medications, like your NSAIDs, your anti-inflammatories, your GI medicines, over-the-counter. All of these medicines have the antidepressants, for example, all have anticholinergic properties that when added together add up to a dose of atropine, a very strong drug and something you wouldn't just give somebody for no reason. So she talks about you really need to learn your pharmacology well in order to do geriatrics because they're on many, many drugs. Sometimes it's 8, 10, 12, 15 drugs. So she says you need to know about healthcare systems. The things that Dr. Horton was talking about, how the VA has certain benchmarks that you have to meet. And she said, you know, you got to be able to communicate with the family because the family is a big part of the care. You've got to be comfortable with uncertainty. You've got to individualize things, and you've got to learn palliative care. You have to learn, if you can, how to be compassionate. to your patients. She said you should learn from an expert, someone who's very, very good at geriatrics. And I remember in my training, one physician who was just outstanding. I wanted to order an MRI. As a student, I said, well, I'll order an MRI. And he had a fit. He said, you didn't do a physical exam. You didn't do a history. What do you mean order an MRI? So you have to learn from an expert. You have to be cautious with medications like opioids. And this is very important. Think beyond the latest guideline. Because if there's 150,000 journal articles a month, then, and you can't go through all that, that means that you're looking at treatment guidelines. And if you're being paid based on your outcomes on these guidelines, then you're just trying to fit everybody in the same, plug everybody into the same algorithm and come out with some result. And what she said is that these patients don't follow the guidelines. This group, their physiology is different. They don't follow the guidelines. And they don't, you know, you have to think of that when you're treating them. And here's what the reward is. The reward is a patient population who teaches you dignity, who teaches you what it's like to be human, and who is very, very appreciative. So, future populations in Texas are likely to be uninsured or underinsured. We already know there's a lot of underinsured in Texas, maybe as much as 40% underinsured in Texas. We know that there's going to be, unfortunately, more poverty due to educational challenges and challenges within our state. And we're going to have a segment of the older population that's wealthy, that can do what they want, but we'll also have this other segment that has not planned for retirement and that is going to try and live on Social Security at a time when Social Security is going to be burdened. There'll be an educational disparity. There's going to probably be more obesity and chronic disease, and the urban will be proportionally younger, whereas the rural is proportionally older. Future Texas PAs are likely to be females in primary care, and older males probably more likely to be found in specialty care. There is an increased diversity of PAs. We have more ethnic groups represented in our profession than even physicians do. And we are poised right now to continue to solve part of the problem. But I will submit to you that we're not going to solve the problem of geriatric health care in Texas. PAs are not going to be able to do it. They're not the only answer. We have to have nurse practitioners. We have to have social workers. We have to have team approach to care. We have to have more physicians. We're not going to be able to do it just with PAs, even if I would like that. So what's going to happen? We'll have to have more foreign medical grads in Texas. And that brings up a whole host of issues, but it's going to happen for us to meet the need. I appreciate your attention and I'm willing to answer any questions. Yes?
It seems like the nursing group is about the same parallel. Because, you know, I predict the VA nurses in 5 years, half of us will be gone.
Right. Nurses are aging as well, so you have nurses in that baby boomer cohort who are going to retire, who've worked hard, who've been there, done that. You do have nurse practitioners. There's about twice as many nurse practitioners in Texas as there are PAs. So there are a lot of nurse practitioners in Texas, but they don't always work as nurse practitioners. They're licensed, they take that, but they may go in and work the floor, or may become a director of nursing, or may work administratively and not actually provide direct patient care. So you're right, the same challenge is present in nursing. Well, thank you for your attention.